everyone. Thank you for joining me for ACEP's Capital Minute, a look at what's happening in Washington right now that's affecting emergency physicians and patients. I'm Laura Worcester. For the next 30 or so minutes, I'm going to give you an update of what's happening in our nation's capital, and then we'll open it up for questions. You can submit them at any time using the Q&A feature at the bottom of your screen in Zoom, and then I'll answer them live after my update. We're going to start today with an update on the COVID vaccine rollout. Then we'll turn our attention to what's happening on Capitol Hill, including the new 3-day buprenorphine rule that was included in the most recent continuing resolution, an update on surprise medical billing, and our advocacy strategy, and our outlook for the end of year legislative package. Last week, Pfizer's COVID-19 vaccine received emergency use authorization from the FDA, and it started to be distributed to healthcare workers like yourself. This week, we're expecting the Moderna vaccine to get approved. ACEP has been meeting with the CDC every other week since basically the start of the pandemic to both share information and ask questions that we receive from emergency physicians from across the country and receive the latest updates. Last week, the focus of our conversation with the CDC was on the safety and efficacy of the Pfizer vaccine and how the physician community can work with the CDC to help instill public confidence in the vaccine. The CDC is instituting a three-pronged strategy for reinforcing confidence in all of the COVID-19 vaccines, which is building trust, empowering healthcare personnel, and engaging communities. It has also developed a plan so that medical centers, clinics, and clinicians can use to help with this. ACEP is compiling these materials along with other important and useful resources as the COVID-19 vaccines are distributed to the healthcare teams and the public, and its own COVID-19 vaccine toolkit, which is available on the ACEP COVID microsite. Among the materials is a recent statement that ACEP put out about priority access to the vaccine for emergency physicians. That statement is intended to encourage hospitals and state policymakers to make every effort to ensure that all emergency physicians and frontline staff have the opportunity to be vaccinated as soon as possible. In addition, ACEP's PR team will soon be releasing a public-facing toolkit, which will provide resources to educate patients and answer their questions about the vaccines. As part of the stopgap funding bill approved by Congress late last week to keep the federal government funded and open for an additional week and allow the Congress to wrap up its year-end legislation, emergency physicians will now be able to dispense up to a 3-day supply of buprenorphine at one time to a patient suffering from acute withdrawal symptoms in the ED. The funding bill included the Easy Medication Access and Treatment for Opioid Addiction Act, or the Easy MAT Act, which ACEP has been working on with Congressman and emergency physician Dr. Raul Ruiz of California since last year. Up till now, the 3-day waiver for emergency physicians was helpful in that it allowed them to provide buprenorphine in the ED without having the X waiver themselves and going through all the training and application for that. But patients still had to come back every 24 hours within the 72-hour window it provided, while they waited arrangements for long-term treatment for their substance use disorder. Because many patients, as you know, have difficulty coming back to the ED each day for a variety of reasons, this becomes a barrier to patient care, and providers can be less likely to initiate such treatment. So now, with the ability to give 3 days of treatment at one time, patient care is improved. However, emergency physicians will still need an X waiver to prescribe buprenorphine for the patient to access outside of the ED post-discharge. ACEP is continuing to advocate for this to change. We've been supporting legislation. We've worked with others in a coalition to get rid of the X waiver process altogether. But in the meantime, this change to the 3-day waiver is a big improvement and will hopefully keep patients having additional access to treatment. A lot of this is through the tenacious work of ACEP's leaders, DC staff, and many of our members who have flagged this as a big issue. As a next step, the Drug Enforcement Administration, the DEA, will need to revise regulations within 180 days after the bill is signed into law. And I believe the bill was signed last weekend. So moving on, there have been recent efforts on Capitol Hill to push legislation on surprise medical billing before the end of the year. In fact, late Friday, we finally saw language for a new compromise bill, which is now called the No Surprises Act, excuse me. So that came out late Friday night. It's about 370 pages. So ACEP and staff spent all weekend going through the language with a fine-tooth comb. A lot of this is really complicated, so it's not so straightforward as, okay, we read the bill, it's good, it's bad. So the language that's in the No Surprises Act is now supported by all 4 committees of jurisdiction for healthcare in Congress, including the House Ways and Means Committee, whose legislation introduced late last year was supported by ACEP and had been sort of the last holdout on advancing legislation on surprise billing in Congress. So in terms of what's in the bill, it does level deductibles, as we call it, which is that for emergency patients, if they're getting care that's out of network, their deductible will be the same as if it had been in network. So that's a big difference and a big improvement over current law, especially when a lot of patients have really high deductibles, not just in network, but even higher out of network. And really, if you have a $4,000 out of network deductible, you might as well not have insurance for the purposes of your emergency department visit, because it's going to be entirely out of pocket. So this would be a big improvement if it's passed into law. There's no median in-network benchmark for any initial payment that the insurer would give to the out-of-network provider. It does include baseball-style independent dispute resolution, or IDR, or arbitration, with no threshold to access it. And claims can even be batched for administrative simplicity. One of the big sticking points, though, that's in the legislation that we see as a problem is it has this 90-day cooling off period. What that is that once you take, if you're the out-of-network physician, once you take a claim to IDR, any future claims for that same or similar service with that same insurer can't go to IDR for 90 days. You can, during those 90 days, kind of save them all up, and then on the 91st day, bring them to IDR. So it depending on how you interpret the language. So there really isn't, at least staff have told us in the congressional offices, that they don't intend any part of your claims to be completely excluded from going to IDR. It's just you have to wait. And so we have stated a lot of concerns on the impact this could have, especially on smaller practices who, if they're being drastically underpaid by the insurer, will be faced with cash flow issues. So this is a big problem in the legislation. It is also important to note that Senate Leader McConnell will still need to sign off on inclusion of this surprise billing language in the year-end package. And that itself is already fraught with potential controversy and has been a complicated negotiation for him. So this is by no means a sure thing that it's going to be in there. We know some of you have been wondering what ACEP's position is on this legislation. The ACEP board met on Monday to discuss the draft bill, and the consensus at the time amongst them was to stay neutral, but weigh in with our concerns about the more problematic provisions that were included, such as that 90-day cooling off period. So early Tuesday morning, which was yesterday, actually, now that I think about it seems about 10 years ago now, we sent congressional leadership in the House and Senate a letter that talks a little bit about the bill. It does point out some of the improvements in it that we appreciate that they made, but it also highlights some of our concerns, including that serious concern about the 90-day cooling off period, the way it's currently written. So why did we decide to stay kind of neutral? You may have heard that AMA is now opposing. They were not opposing yet, first of all, I should say, at the time of the decision, but even without that, there's a lot of factors that went into this decision and strategic approach. If you're comparing us to the AMA, they represent physicians of all specialties, including primary care. So it's just they have different issues that they need to represent their members for, versus we just represent you, emergency physicians. Another big issue is that we're still working to ensure that Congress has a fix in a year-end package to at least temporarily avert the 6% cuts for Medicare that emergency physicians will be hit with on January 1st. I'll update you in a bit on the details of that, but it's important to remember that these two issues easily become interlinked in Congress's minds, because they both have to do with reimbursement and they both have to do with emergency physicians and other specialists. Congress has been working for 2 years to enact surprise billing legislations, and they have made a bunch of concessions to try and keep physicians from opposing anymore. And this compromise bill has come a long way from the Senate Health Bill in mid-2019, which had just a straight benchmarking approach where all out-of-network claims, no matter what, would be reimbursed by insurers as the median in-network rate for that geographic area. There was no IDR, no arbitration. We then had the Energy and Commerce Committee's bill, which was amended to add an IDR process, but only if a service was over $1,250. So that's wildly out of reach for emergency medicine, as you know. Next, we had a compromise bill between Senate Help and Energy and Commerce that brought the IDR threshold, the threshold needed to access IDR, down to $750, which was still very problematic for emergency medicine, given the reimbursement levels for even the 99285 codes. So in Congress's view, they made a lot of concessions to bring the physician community to a place where they'll stop opposing surprise billing legislation, and incorporated almost all the changes we asked for in our most recent letter that we sent to the Hill with our specialty colleagues just in October, just a couple months ago. So the thinking is, if we yet again oppose what they see as a reasonable compromise, and as a side note, I should note that the insurers have been pretty vocal over the last couple of days about how problematic this latest bill is for them, and that they see it as a giveaway to physicians. So that's just something to keep in mind. Then there may not be very much goodwill left for Congress, if any goodwill, to help the physician community on these E&M cuts. So there's a lot of moving parts to this. If we were to write surprise billing legislation that is kind of like the ideal for our physicians, it would look nothing like the No Surprises Act. That is definitely the case. We would not have this cooling off period. We would not have median in-network even included as a single factor for the arbitrator to decide with. None of that would be in there, but that legislation would never go anywhere. And we've even tried several times to introduce legislation that even only had like some of those things, and we were shut down pretty quickly each time. There was a lot of kind of animosity that started to build up by members of Congress in terms of what they viewed as the physician community being too resistant on any surprise billing solution. So it really is kind of the latest compromise that has come a long way. And you can't just look at it in like a standalone lens. It has to be considered with all these other factors. So we're not supporting it. That's definitely clear. There's no way we could support something that has this like really problematic 90-day cooling off period the way it's written. So I just want to be clear on that. But in terms of, if you're wondering why aren't we hard opposing this? Well, if we hard oppose this and it did get killed, when this comes up next year, because it will absolutely come up next year, this will have been kind of the high point in terms of what we could get, because at that point, why should they make any more improvements to bring the physician community on board when from their perspective, all the other improvements they've made, physicians still oppose. Clearly, they don't actually want to fix surprise billing. So why should we help them? So let's just do something that, helps the insurers and patients and doesn't take the physician community into consideration. So this is kind of like where things currently stand. But again, McConnell has to sign off on inclusion of surprise billing in the year-end package. As of half an hour ago, it was still up in the air whether he would or not. So that's something that is still kind of more to come on that. But back to the end of year package, why don't we look at some additional measures that we're trying to get included. As I noted, our efforts continue on stopping the E&M cuts in Medicare that start January 1st. And on this past Thursday, Senator John Boozman of Arkansas introduced the Senate companion to the ACEP-supported Hold Harmless legislation that was sponsored in the House by Representatives Ami Bera and Larry Bluchon, both of them physicians. The other original co-sponsors of this new Senate bill are Senators Tom Cotton, Kevin Kramer, Susan Collins, and Cindy Hyde-Smith. The legislation represents one proposal that's being considered right now by the Committees of Jurisdiction and Leadership in trying to fix the E&M issue. But given the late introduction of that Senate bill, ACEP and our healthcare provider coalition partners have been working with individual Senate offices to garner support for the legislation in the very narrow window of time that remain before Congress adjourns, which is expected to hopefully be by the end of this week. As well, we are working to support inclusion in a COVID relief package for the year end of common sense liability protections for emergency physicians that would apply retroactively to the beginning of this year and extend until the end of the public health emergency. And then finally, we continue to advocate for the Dr. Lorna Breen Healthcare Provider Protection Act to be included, named after an ACEP member who died earlier this year as a result of suicide after providing care during the COVID surge in New York City. This important legislation would provide support to frontline healthcare workers and seek to address barriers that currently exist to emergency physicians accessing care. So that wraps up our federal advocacy updates. With the holidays approaching, we will not have a Capitol Minute on December 30th. Instead, we'll have a special edition the following week on January 6th, where we'll be able to provide an overview of the new Congress, which will already be seated by then, and our high-level advocacy strategy. And then after that, we'll be back on our regular bi-weekly schedule that begins on January 13th. If you're curious about our schedule, you can always check our webpage at acep.org/Capitol30minutes to get the latest. But I'm happy to start taking your questions now. Remember, you can submit them using the Q&A feature of Zoom on the bottom of your screen. First question. Okay, on surprise bills, is it per TPA or per employer payer? And then how much does IDR cost? And what if nobody is in network? Okay, so the per TPA or per employer payer, it's for, if you're asking about the median in-network rate that's used on the back end as part of the arbitration kind of factors, it's for that plan, that particular plan in that geographic area. It does not, our understanding is it should not include, if they have like a Medicaid managed care or a Medicare Advantage plan, it should not include those rates, just their commercial product. In terms of how much does IDR cost, that still will be determined. Some of that depends on a kind of regulatory process that the Secretary of HHS will develop. The cost, it's loser pays arbitration, so the cost will be borne by the non-prevailing party, but it should be kind of strictly based on how much this actually costs the IDR entity to provide the service. There is an additional fee that will be included as part of arbitration that all parties have to pay. That's just going to be really the portion of the cost to HHS of standing up this program divided by all what they view as or estimate will be all instances of arbitration. So we don't expect that to be a lot, but it is one of the kind of outline questions of the process. In terms of what if nobody is in network, so how can you establish a median in network if nobody's in network is what I suspect that is about. So all of this takes the median in network from January 31st, 2019 for that plan, and then increases it each year by CPI-U, Consumer Price Index Urban. And so the reason for that is so that insurers can't start dropping their higher cost in-network contracts to bring down the median. This all basically already happened in January of 2019, so they can't game it. This is retroactive, is like the retroactive starting point, and then it just increases annually for inflation. So if though back in January 31st, 2019, that plan didn't have anybody in network or is a new plan, they'll use what's available from a database at the time. HHS will use what's available from a database, especially if there's a state all-payer claims database, to estimate what that amount should have been or what it would be for comparable plans. And then again, would increase annually by inflation. Let's see if there's other questions. Where can I find the letter that ACEP sent to Congress? We're adding it to the acep.org Federal Advocacy Surprise Billing Overview page. So acep.org, then click on Advocacy, Federal Advocacy at the top. And then there should be a section for surprise billing, and the letter should be being added there. I think it's also being included in the morning emails that some of you might get. Okay, it is in fact on the acep.org webpage where I said, so that's already up there. Other questions? Let's see if there's any additional ones coming in. The changes to the 3-day rule are important for physicians and patients. So what are the next steps for our advocacy related to the X waiver? So we will, early next year, we will kind of restart in the new Congress, we'll restart our efforts on that. As we have a lot of new members of Congress that come in, we normally put together kind of a whole package of materials for them to educate them on issues important to emergency medicine. And I expect this will be one of them. And then we'll see if we can go about, I think there was legislation in this Congress to get rid of it altogether. So we'll make sure we can support any efforts to get that reintroduced, because once you change to the new Congress, you can't work from the old bills. I mean, you can use all the same language, but they do have to officially be reintroduced. So we'll work to support those efforts and to gain co-sponsors for them. For another question on surprise medical billing, what are the reasons for AMA opposition? I mean, honestly, I couldn't tell you exactly. I know that their Council of Legislation met, and I guess that's where some of their determination came from. But I don't know their specific. I know that they do have existing policy that was passed by their House of Delegates that does guide, not just guide, that actually requires them to take certain policy positions sometimes. And I do know they have, I think, some pretty specific policy on surprise billing. So I imagine some of it is that they do have to hold to that. Okay, are market-based costs included in terms of the entire GUL criteria? I'm doing this a little from memory. So I know there's things in there about complexity of the case, certainly the complexity of the case, the skills and experience of the physician, their quality measures and outcomes, those can all be brought. There is also whether there's a history of good faith or not good faith efforts by either party to enter into contract. So that'll be included. And then on top of that, the physician can, well, either party can bring anything they want to arbitration in addition to all those things I just mentioned, and they have to be equally considered with all the other things. The one exception to that is usual customary rate. So charges can't be brought. That's specifically excluded in the legislation. And the reason for that is the way the Congressional Budget Office scores charges, because they're not kind of like a straight, like, sort of fee schedule type thing. The Congressional Budget Office kind of scores it as like almost infinitely expensive because they don't see an upper limit. So when there's no upper limit, CBO will score something at like the worst case scenario that it sees. We did a ton of educating to try to show them why that's not the case. We talked about fair health and all that, but that's just where that is. So charges had to be explicitly excluded in terms of that. So everything that's in there other than charges has to be equally considered. Anybody can bring anything else they want, but the median in-network is used as one of those factors for arbitration. But again, it gets equal weight to anything else the physician wants to bring, plus some of those GUL criteria. So I don't know if there's another question. Do historical payments, if not in-network? I'm going to guess that was the question is, do historical payments count if not in network? That's a good question. It's sort of maybe a workaround for the UCR prohibition. And I know AMA, as of like last night, was trying to get like legal opinions on this. So it was not at all clear cut, but let's just say if that did end up being the case, that would be a good thing, because I think it's a little bit of a kind of end around to be able to get some of that information to the arbiter as well. All right, so question is this compromise a win for emergency medicine and patients? And what do you think was the biggest factor in helping Congress reach the compromise? Is it a win for patients? I do think it's a win for patients. Is it a win for, it does provide them with a lot of protections. One of the things that we were really happy was included is a provision that ACEP actually came up with the idea for and got Congress to pay attention to, and that's to have require insurance companies to put the patient's deductibles on their insurance card, right? Right now, if you look at your insurance card, most of them anyway, it's like usually like 80% of them, because I used to have members of Congress pull them out and take a look at them. All that's on there usually is like the copay, like the drug copay and the office visit copay. At most a co-insurance, but half the time that's not even on there, and nobody understands what a co-insurance is anyway. But deductible is not on there. I've only seen one instance of seeing a deductible on the health insurance card. So having that on there, every time the patient pulls out their card to go to the doctor or anything else, they're reminded of what their insurance is not covering. Obviously, in an emergency, we would hope that they just seek the care they need. But the idea is more that they understand what their premiums are paying for, and more importantly, what their premiums are not paying for. And I think that's going to bring additional scrutiny to the insurers. There's some other transparency requirements in there, much stricter requirements about insurers making sure their provider directories are up to date. So I think that will help. And there is also a 1-year study in there calling for a GAO study on network adequacy. Yeah, it's just a study, which we know that's not going to change anything, but it can help inform congressional efforts next year. That our understanding is there will be some work being done to add additional protections for patients around insurance coverage. And so I think having the results of that study help inform that could be a big help, and just get more attention to all the issues surrounding network adequacy and the lack thereof. Is it a win for emergency medicine? The way it's written, no, I don't think it's a win for emergency medicine, but I don't know that I would call it like an outright loss either. We have heard that they're making some improvements to it. The question is how much of an improvement? So that also kind of complicates if somebody, let's say, is considering whether or not to oppose. You might be working to oppose something that maybe is fixed. My sense is they're not fixing it to the extent of taking the 90-day period, cooling off period out entirely, but I think it's important to see updated language before we kind of figure out our next steps. So last question, we have about 2 minutes left, I think. What's realistic to achieve before Congress adjourns? Could we see the Green Bill included as part of a relief package? I would say as of yesterday or the day before, there were still some efforts to get, I mean, ASAP obviously has been working to get the Green Bill. But I would say as of yesterday, there were still efforts by congressional folks to get the Green Bill included as part of a relief package. Again, I'm sure you've seen some of the news on the COVID relief package. It's really, really controversial, and it's been stalled for months. So that's been the biggest barrier, but everybody is still trying to get it in there. So we hope that it can be, but we're not expecting it just because how complicated this gets at the last minute. That being said, it's something we'll hit the ground running with early next year as soon as Congress is back to see if we can get that through. I think there'll be something to help on the E&M cuts. I don't know how kind of comprehensive a solution will be, but we're hoping it'll at least delay some of the impact so that everyone's not getting hit with this during the pandemic and can get a little relief. So I think that's realistic to expect something in there on E&M, but I don't know if we can expect that there'll be something in there that is kind of fully meeting everybody's needs. So with that, we're going to wrap it up. And again, tune in when we are back on December 30th for our year-end special update, and then we'll go back to the every 2 week schedule on January 16th, I think we said. Thanks again, everyone. January 6th, sorry, thanks.